Okay, thank you very much, Dr. Wexner. I appreciate the opportunity to come and speak to you today. This is my disclosure. So we're all very familiar with the treatment paradigm for rectal cancer. Decisions are mainly based on clinical staging at first, and for locally advanced tumors of the middle and lower third, those patients normally undergo neoadjuvant chemoradiation followed by surgery. If they're not locally advanced, they usually go right to surgery, and then after pathologic staging, the decision about adjuvant chemotherapy is also rendered. However, we know that a lot of the decisions that we make are based on imperfect clinical staging or imperfect pathologic staging as well. And there's multiple issues of overtreatment and undertreatment. And you can see just within this algorithm, there are multiple spots along the treatment decisions where you can decide to give or not give therapy or what types of therapy to give. Well, when we look at rectal cancer outcome, the paradigm that I like to think of is that there are two main factors that are involved. There's the surgical aspects or the technical aspects, and then the biological aspects as well. And you could have various combinations of each, and each of these influence your outcome. Well, we all know for colorectal surgery, there's no such thing as bad surgery. So if we look just focusing on the good surgery, there's good biology and there's bad biology. And what we try to do is figure out, are there things that can help us predict who are the bad actors along biology terms? And that's what leads us to talking about personalized medicine. You can't go to any conference nowadays, whether it be surgery or medicine, without talking about how the field is going towards more personalized care. And can we use this patient or tumor information to assign better prognosis and determine better responses to our therapies, and therefore tailor the treatments for individuals? And the days of just fitting every single thing into the same spot, such as putting a square peg in a round hole, those days are going to be gone. And we hopefully can use genetic and molecular markers to develop more personalized treatments. Rectal cancer is a perfect disease to try to come up with these paradigms. We need to have better prognostic models so that we could determine who gets the right therapy and limited toxicity. We need to have more precise pre-treatment staging as we're figuring out more and more who responds, who doesn't respond. And also we need, more importantly, I think, in my opinion, the predictive models for neoadjuvant chemoradiation so we can improve our effectiveness of treatments, decrease toxicity, and then potentially even change our surgical approach. The problem with all this is that we're really limited in our current knowledge. There's no standard practical clinical applications for any of the markers that we talk about or anything that's out there. I'd love to be able to stand up here right now and say that if we do this, we take a biopsy, we measure this, and we know what to do. But unfortunately, this is not the case. There's a lack of any validated models. Most of the studies that are out there are based on retrospective reviews of tissues. There's a large variability in the study designs and outcome measures, and there's really a lack of prospectively collective data. On the positive side, there is a lot of research being done, and that research has shed light on the biology of rectal cancer, and there's great potential, and I do think things will be squared away or figured out in the near future. So what are some of these potential markers? And that's what I'm going to talk about here. And I have an asterisk up there to say this is not a comprehensive discussion. There's over hundreds of markers that people have looked at and report on in the literature. I've decided to focus on a couple of studies that I think are a little bit better done, as well as what I find interesting myself. And I'm also not going to focus on prognosis and a bigger field of different ways to go, but more on what are the response to neoadjuvant therapy, so we can focus our discussion within limits of time. So some of the individual markers that I'm going to talk about are KRAS mutations and Thymidylate Synthase SNPs, or single nucleotide polymorphisms. And then I'm going to talk about the whole genome analyses, particularly gene expression profiling that's been done. So first, KRAS and the epidermal growth factor receptor pathway. EGFR is a tyrosine kinase, which stimulates signal transduction and cellular proliferation. KRAS is a downstream effector within this pathway. So when the receptor is stimulated, KRAS gets turned on. If the KRAS gene is mutated, that turns the whole pathway on, constitutively on, so it's always being produced regardless if it's being stimulated at the surface of the receptor. KRAS has been used as a marker in colon cancer for both prognostic and predictive values, and treatment decisions are also guided by KRAS mutations for colon cancer, for metastatic disease, and also colorectal cancer can be brought into that group as well. And NCCN currently recommends that patients with suspected or proven metastatic colorectal cancer should have tumor tested the KRAS gene status. But looking specifically, where do KRAS mutations fit in with response to neoadjuvant chemoradiation? First of all, KRAS mutations are present in about 30% of rectal cancers. And there's been some conflicting data, particularly earlier data in the literature, that says KRAS mutations are less responsive, but yet there's just as many studies that might say there's no difference at all based on the KRAS mutation. As some of these other studies have drilled down a little bit deeper, though, we've looked at specific codons where the mutation is located, and even down to the level of which specific amino acid is mutated or switched in these studies. And actually, those are starting to shed a little bit more light on the effectiveness of this. And in particular, there was a study in 2009 which showed that the G12V mutation had a higher rates of tumor regression than G13D. It gets pretty detailed, but there's one aspect that people are starting to look at. More recently, this is from Dr. Garcia Aguilar's group out at City of Hope when he was there, looked at the KRAS mutations in response to neoadjuvant chemoradiation. He looked at, this is one of the larger studies in the literature, looking at 148 stage 2 and 3 patients, and he looked at the mutations in the pre-treatment biopsies, which would be the best clinical application of this. 60 patients had a KRAS mutation, and their endpoint was basically a pathologic complete response. And they found that KRAS mutations, or tumors with KRAS mutations, were a lot less likely to have a pathologic complete response than those who did not, or that had a wild-type mutation or wild-type KRAS status. And in particular, there was one group, people had mutations in codon 13. Granted, there's only 12 of them, but none of them had a pathologic complete response. Suggesting that this could be a group that we could study, saying if you had this mutation beforehand, then either try an alternate treatment regimen or maybe not even do chemotherapy at all or chemoradiation at all. Dr. Aguilar's group also did a combination profile looking not only at KRAS mutations, but also looking at some other DNA mutations. This is a multi-center group, 132 patients. They looked at serum DNA for mutations as well as polymorphisms. And they found a combination of 3 markers was fairly, had a decent predictive power for response or non-response. There were 3 markers, one of them being KRAS mutation. The other 2 are listed there as cyclin D1 and NADPH. The SNP in that, all those independently had some predictive power for non-response. This was done internally validated using statistical methods on the same data set and found as about a 70% valid predictive model and 97% positive predictive value for non-pathologic complete response, which, again, distinguish that as the people, it doesn't mean that they, you can't use it to say necessarily that they had a complete response, but looking at the people who aren't going to respond. Moving on to thymidylate synthase. This enzyme is responsible for 5-FU metabolism. There's genetic polymorphisms, or SNPs, where there's a single nucleotide polymorphism where a single amino acid is switched, and some of those SNPs have been responsible for drug resistance, influencing response to therapy, particularly for 5-FU. And there has been conflicting evidence. Again, it's very muddied waters, but the balance of all the literature favors an association with response to chemoradiation. One of the more interesting studies is something in recent years. Jim Fleshman's group was involved in this out of WashU originally. So there's one previous study that showed the differences in tumor downstaging between the different genotypes of the different SNPs, and that the people who had a good risk had a 60% chance of having a response or tumor downstaging, whereas people with a poor risk genotype only had a 22% chance. So they moved forward with this and actually did a prospective phase 2 trial using the TS genotype to direct preoperative chemoradiation therapy. For the good risk patients, they underwent standard therapy. For poor risk, you had standard therapy, but also included weekly doses of irinotecan. When they looked at the downstaging, again, you could debate whether downstaging from clinical to pathologic is a good endpoint or not, but they raised up the people in the poor risk group with the addition of irinotecan, raised the downstaging rate up to about, or actually the same as the good risk group. And then they also looked at YPT stage and showed that the poor risk group with the addition of irinotecan actually had double the YPT0 effect on that. I've not seen any further work done on this to date, but again, it's a very promising strategy to potentially increase responses. So I'm going to spend the last few minutes talking about gene expression profiling. So the general theory or premise behind gene profiling is that there's specific genetic changes that determine the clinical behavior of the cancer. And I think we're a bit naive to think that a single marker is going to be able to decide what's going on in the whole biological response, but probably a combination of markers that represent various pathways. There's been a big advancement over the last 5 to 10 years in high throughput technology, which has allowed a more systematic approach to disease genetics, where you can actually look at thousands of measurements across an entire tissue in a single experiment. In terms of predicting response to chemoradiation, this was tried back also all the way in 2005, which was a retrospective evaluation of some of the patients from the German rectal cancer trial. As you're all aware, this was long-course chemoradiation. The endpoint in this study was looking at T-level downsizing, and they came up with a 54 gene signature, which was, again, just internally validated, not on external samples, but showed us about 83% accurate to predict if it would downsize or not. A group from Japan looked at 52 patients that had preoperative radiation only. They looked at histologic response. They had a 33 gene signature. Again, decent performance, but internal cross-validation only. Another group out of South Korea, 31 patients. They looked at a complete pathologic response versus non-response. You see the 261 genes are differentially expressed. They did do a small validation set of 15 samples from a different population. It's found to be 87% accurate. One more study, again from Germany, looked at 43 samples, histologic response, 42 genes, internally validated only, 71% accuracy. And I show you all these studies not to pick one particular one out, but just to show you the differences in there. There's different endpoints, different responses, small numbers of series, and it's just setting up why we have some of the problems that we have. The most recent signature that's been published is out of Australia, actually. They looked at 51 patients and found their endpoint was a histologic good tumor response, and they developed various classifiers. Their best performance was 82% sensitivity and 89% specificity. However, of the various classifiers that they tried, the ones with the highest sensitivity had a poor specificity and vice versa, as you might expect. When they looked at, this is where the study really is different than the others out there, and this is, I think, very informative. They looked at what these predictive classifiers do based on published databases. So there's gene banks that are out there that you can take your signature and test in these various gene banks. And when they looked at the various classifiers that they did against all the other gene signatures that have been published, sensitivity and specificity ranged only from 21 to 70%, an overall poor performance. So kind of a naysayer from this study showed that their conclusion that these results show that the clinical utility of microarrays in predictive medicine is not yet within reach for rectal cancer, and alternatives to microarrays should be considered for predictive studies in rectal adenocarcinoma. I'm not that grim about the outlook of things. I think more of this is the problems in the design setup. And there's a lot of the reasons for the lack of overlap between these studies, that there's small numbers of cases, as I showed. A lot of them are different treatment protocols, the duration of treatment, the chemotherapy plus minus, or radiation plus minus chemotherapy. The definitions of response are all different. There's different microarray platforms that were used. Statistical analyses were different by each study. And biologically, these are very different patients. You have the Asian populations might not be the same as North American or German populations as well. So when we look at the future directions, I think we can answer the questions using some of the knowledge that we have out there if we have carefully designed prospective validation trials. You can look, this is just one algorithm, the flow chart here. You have a diagnosis and biopsy or after surgical resection. At any one of given points in this algorithm here, you could pick out a sample and do some analysis and try to figure out a decision point. Ideally, with genetic profile testing, you'd figure out someone who's low risk and might not benefit from chemotherapy or radiation and just do surgery alone and minimize toxicity. If they're high risk, perhaps do standard therapy, or high risk for not responding, standard treatment, maybe surgery alone, or some experimental neoadjuvant. I'm not proposing any one particular protocol to try, but I think we do need to design prospective trials and take the lead in this ourselves to try to sort out what's going on. Just a few summary points I want to leave you with. Biology definitely does influence rectal cancer outcomes. There are genetic and molecular markers that have been identified and under investigation. However, there's no prospective validation as of yet and no practical clinical applications. But I do think that there will be increasing integration of this information into clinical practice in the future, and we as surgeons need to take the lead in this effort. Thank you very much.